Welcome to Key into Quality, the Mayo Clinic podcast where we explore the people, practices, and principles that elevate healthcare quality and safety. I'm Dr. Tim Morgenthaler, Professor of Medicine and Vice Chair of Mayo Clinic Quality. In this episode, we're asking, how does a multidisciplinary team reduce catheter-associated urinary tract infections while protecting staff safety and become stronger in the process? Co-hosting today's conversation with me is Sherry Nemec. Sherry?
Welcome, everyone. I'm Sherry Nemec, Consultation and Relationship Manager for Quality at Mayo Clinic. And Dr. Morgenthaler, this is such a good topic because I know so many hospitals are challenged by reducing CAUTIs.
Yeah, I mean, CAUTI has been, CAUTI for our listeners is short for catheter-associated urinary tract infections. Easier to say than all of that. But CAUTI, even though it's 5 letters, is probably like a 4-letter word to most people who are in quality because we're forever trying to reduce the frequency of these infections. People who are familiar with patient safety understand the challenge. Although the national data recently show meaningful progress and reduction, with CAUTI rates in acute care hospitals significantly lower than they were in 2015 and continuing to decline, no one has achieved a persistent zero. And some places really struggle a lot to get the rates down to where they want them. And these are important infections, things that we do not want to have happen to people. So today's conversation, I think, is going to be less about a single infection prevention problem, which is a good problem, but it's going to be really more about the teamwork required to improve care and probably applicable to many other important problems. I'm going to let our guests tell the story in their own words rather than try to predict what they're going to say. But I think we're going to learn about what they faced, how they worked together, what they learned along the way. Our aim is really simply to listen together to the broader lessons about quality, safety, trust, and collaboration that we can hear from this conversation. So with that, we're just delighted to welcome 4 guests from Mayo Clinic in Arizona. Gina Hull, who is a coordinator for nurse infection in the Department of Nursing. Eric Siebenek, who's a performance improvement advisor in quality. Chris Allery, who's a clinical nurse specialist in the Department of Nursing. And Bridget Kiley, who is also a nurse quality worker from our Department of Nursing there in Arizona. Welcome you all to Key into Quality. We're grateful to have you with us.
Yeah,
Thank
welcome,
you.
everyone.
Yeah.
Thank you.
Well, before we really dig into some questions here, I'd like to just invite each one of you to briefly introduce yourself, your role, the setting you work in, what's your connection to this CAUTI prevention work. And maybe I'm just going to start with Gina. Gina, can you share with us a little bit?
Yeah. So I come to this group as an infection preventionist at Mayo Clinic. I've been an infection preventionist there for about 6 years. And when I joined the Mayo Clinic team back in 2020, I was a brand new infection preventionist. And so that was about the time that I think COVID hit. And
Mm.
so it was kind of a interesting time to start this kind of work. I was off rocking and rolling right away during a brand new pandemic. So
Total immersion.
yes, absolutely. Jumped right in with both feet. So it's been a really, really exciting 6 years. Besides CAUTI, there have been other quality improvement projects that I've had the opportunity to work on. I think that's one thing that Mayo Clinic is really, really good at. So really good at building their team members as quality improvement specialists. And I'm here to kind of talk a little bit about that. And
Yeah.
also, I was tasked with leading the team with a co-leader, Chris Allery.
Well, fantastic. Maybe Chris, we could have you go next.
Sure. I'm Chris Allery, clinical nurse specialist here in Arizona. I support medical surgical units on the inpatient side and then some various ambulatory areas. Back in 2020, like Gina, was assigned to work with Gina and really identify some opportunities to improve CAUTI. I had actually made this part of my performance evaluation as a goal because I noticed that we were really challenged and having a problem with CAUTI. And I just kept hearing, well, it's COVID, and I kept saying, no, but why? We need to figure this out. Why? So this is when we formed this team and really work collaboratively with multidisciplines and eventually leading to a gold award on this, and then also a team award. So we are really excited to share our work with you and what we learned.
Well, fantastic. And thank you. And Bridget, how about you? What's your story?
where can I begin? Let's see. I've been with Mayo Clinic, Arizona for 28 years, coming up next month. And so in
Wow.
2020, when we started this initiative, and all of it's been in the ICU here, pulled forward. So we didn't have this West Tower, we had the Central Tower, and I was working clinical in many roles in the ICU as far as ECMO transport, ECMO care, all open hearts, transplants, all the patient populations, team lead, rapid response. And during 2020, our quality specialist had moved, and I had interviewed for the role and got my master's in health law and thought I'd go into quality and really the patient focused care that I've continued to give throughout the years. And so I became involved in resuscitation subcommittee, ethics subcommittee, and became the quality specialist, and COVID hit. So I was in this role, and then nobody came to the office, and all of us were charged with these infections in the ICU that were overwhelming. We had a very sick patient population. We had safety officers at the time watching everyone don and doff proper PPE. We didn't know what we were up against. We didn't know, what to do or how to treat these patients. We were looking at mostly European data at the time to figure out, the trajectory of our patients. But this team really came together, whether remotely and or in person, because we weren't really allowed to meet in person, to work collaboratively along with our multidisciplinary other colleagues to really tackle this and figure out what is best for our patient, because there's no other strength as a team as when you're, regardless of the circumstances, that our patients deserve the best care we can give them. So that was the drive of this team. And I continue to pop into CAUTI prevention, even though I don't do that as much anymore. And my nickname was BK back then. So I'm like, it's just BK saying hi. So we really have established a great friendship as well as a teamwork collaborative. So that's and right now I'm in the ICU continued as a resuscitation coordinator and part of resuscitation subcommittee secretary. So thanks for everything. I guess
Wow,
Eric's
Bridget.
next.
Eric.
Yeah, sure thing. Hi, everybody. So my name is Eric Stevanek. I'm a performance improvement advisor. I work for practice quality, and I was brought on late in 2020. I've been here at Mayo Clinic for 14 years now, and there was definitely a need for some HAI improvements. And I think, later into 2020, I was added to the team to help provide guidance into DMAIC methodologies, our QI program here at Mayo Clinic. So I helped to guide the team, the leadership of Gina and Chris towards following DMAIC, and I helped a little bit with project management, some stats work in the background, analysis, everything that the team needed to be successful was, I kind of rounded out that need. So.
Great. Thanks everybody for joining us. We're really excited to have you all here today. I know, Bridget, you started going down this path just a little bit, but let's dig into this just a little more. So you talked about the setting, the challenges that were happening around the time of COVID, what kinds of things you're up against. What else can you share with us about that time?
Thanks. I would tell you that it was very unique. Like I said, I've been in the healthcare setting for a long time, and 28 years here and 6 years prior in an ICU in Chicago. So I've seen a lot of circumstances. I've seen a lot of challenges. This certainly was one that I hadn't seen coming or ever experienced before. And all of us were experiencing this, where we weren't actually allowed in the hospital. A lot of us, we weren't allowed to come in the hospital. We weren't allowed to meet in person. We were required mask. We had 3 pods open that were all of a sudden you could hear the air shift, and everything was shut down and then turned into a negative isolation pod. So every pod was closed. Everyone had a safety officer at the front. Every person had a safety officer within the pod to make sure you had all your PPE on correctly. If you left, you had to make sure you cleaned it correctly. So strictly, we were under this kind of fear and intense situation regarding our patients, but also how to protect ourselves. I remember nurses saying, what do you do when you go home and take your shoes off? Do you leave them outside? Do you put them inside? Do you take a shower? Do you have a facility outside your house? I want to bring this home to my family. I mean, there was a lot of fear. There was a lot of challenges. And then as a quality specialist new to the role, I would connect with the team members to say, look, what are we up against here? Our HAIs are through the roof. We're accepting these patients from other hospitals. We're not changing catheters, but is that a thing? And what are we up against? And we didn't really know. So we really worked together as a team to try remotely which was new also because we were very much get to your meeting by 8, leave by 8:50 to walk on to your next meeting kind of mentality. So this was just a different way to collaborate, but we were right there. Everyone was always up for a Teams call. Back then it was Zoom. We didn't even have Teams. So it was Zoom back then. So we had 30 minutes. We were under license under 30 minutes our meetings. And so we, along with the challenges of trying to meet remotely, but really we had such a teamwork approach to our patients and making sure we did the best for our patients. But at the same token, we were there for each other, which was also really important at a time where, we're all human beings and we all have families and things at home. And we really gave how do you give 100% at work with that kind of an environment? And we did, because you know what, we had each other. And oftentimes we would talk about CAUTI prevention and we would talk about hack and prevention, but oftentimes we check in with each other, which really kept our vision going and kept our teamwork strength going where it was each other. So, and we get along really well, which always helps. So that was kind of the environment we worked in. And as COVID lingered and as it went on, and the more we figured out is the more time that we were able to try and figure out what that process looked like with Eric. And he was really able to see the data that we had and how can we tell our story and how can this make sense in the same sense for what really matters is our patients, but how can we be there for each other? So
yeah,
that's kind of set the stage.
Bridget, that you telling it with the passion that you have, it starts to make me remember what that was like. That really was unique in I also have a long career in healthcare, and it just kind of makes me remember all the very, very new things that we were facing and trying to figure out how to do it together and have the right focus. Gina, it was a very unique time. How did the CAUTI project in particular, get off the ground and get started?
Yeah, so during 2020, as COVID ramped up its infections, we noticed that there was a trend where you would have patients with a COVID fever, and then our physician teams would order a urine culture. And so when you pair those two together, you have what we call a surveillance CAUTI. So we noticed that our rates were going up, our incidents were going up, and so the chair of infection prevention and control at the time asked me, I was the person in charge of CAUTI prevention. Mind you, I had been at Mayo Clinic for less than a year. I was a brand new infection preventionist. He tasked me with starting a quality improvement project to bring down CAUTI. And I thought to myself, I don't really know what that is. What's a quality improvement project? And they said, okay, get going on it. Here's the clinical nurse specialist. This is her name, Chris Allery. Reach out to her. I didn't know who Chris was. Didn't know anything. So I remember the first time that I met with Chris, I was so scared and I felt so much pressure because here I was, a new infection preventionist at Mayo Clinic, and I was tasked with bringing down CAUTI. Like, whoa, that is a heavy burden. And so I remember getting a little bit vulnerable with Chris and saying, like, I don't know what I'm doing. Like, I've never done this before. And Chris said, she laughed at me and she said, oh, don't worry, I've done this before. I know, I'll help you. And this will be great. I've been wanting to do one of these projects for years. Let's go. She was so upbeat and so like positive minded about it that all of my fears just kind of dissolved. I was like, okay, I have the right co-lead. Now we just need to find our team members. So with Chris's help, because she had been at Mayo for 20 plus years, she knew all the team members that we needed to collect.
Thank you so much for sharing that with us and with our listeners. I'm just kind of wondering, you hit upon Chris and you made yourself vulnerable, as you said, and you shared this. How has this experience influenced you've now been at Mayo for 6 years,
Yeah.
So how has this influenced your subsequent interactions with teams as they form and move through the organization?
Well, when you're put in a situation like that and you learn like, okay, I don't have to have all the answers, but maybe I just need to lead this team through this. So I just need to kind of figure out how to lead the team and figure out what does the team need and then provide a safe place. So like no idea was a bad idea. there was never any shame. You know, everybody felt like it had to be a safe place. And so as you learn those concepts, you can become a mentor to others who then are tasked with the same type of idea. So in my recent few months, I did get my master's in nursing leadership.
Ah,
And my goal really is, and this is probably because of my experience in quality, my goal really is to like serve as a mentor, to mentor others, to make a difference in healthcare. And that's from my 6 years experience in this type of work.
wow.
So, Gina, you talked about meeting Chris, having Chris as your co-lead. Now you're rolling up your sleeves, you're digging in, you're bringing in other people into this. Any insights or things that you want to share around the way? And then we'll jump over to Chris to talk about successes, wins. But let's
Yeah.
just do a little more on the process.
Yeah, so we did find our stakeholders, but I do have to say that we found a stakeholder who was immensely helpful for us. Our quality team member, Eric, was so immensely helpful with it for us. He walked us through the entire process. Like we hadn't ever done the DMAIC process before in this way, and he's an expert. And our department in the past had, and this is what I had heard as a new employee, had some trouble partnering with the quality team. And I don't know if it was a personality thing or they just hadn't found the right person to partner with us, but Eric has been like such a fantastic fit for our infection prevention and control team. And this was, I think, his first project with our department. And he came in and non-threatening, so helpful. What can I do to help you? Went out of his way. So impressive, brought us all the tools, so many suggestions. That was really has been a really, really great partnership.
Eric, let's just jump to you before we go over to Chris.
Sure
Just
thing.
tell us a little bit about your role then, as a performance improvement advisor and how you've partnered and collaborated to support this team.
Yeah, I just want to say I'm very grateful that I was added to this team specifically because they had such a strong foundation. It felt like I was coming into a family. So I was welcomed right off the bat. It made my job really easy. Um, my job is really like I understand all the quality methodology stuff. I understand the tools, the resources, the project management, and really I just helped this team and guiding them to organize their thoughts in a constructive way. Um, it all started with defining the problem specifically, and that's what we're talking about: building a stakeholder list. Who should be involved in the project? So I helped to guide the team on including the right stakeholders, the people who are doing the work that can give us the right insights to be able to make change. I was able to use my skills to also bring in some data that maybe we hadn't looked at in the past and helped us attribute to what are actual contributing factors that are causing the problems that we're seeing. And then I organized some brainstorming sessions. So the team was able to take those contributing factors and develop improvement ideas and things that we wanted to change about the system, and then I help them implement those things over time. But I'm gonna say I'm very flattered by all the things that Gina said about me, and really it's the experts that are on the team, Chris and Bridget and Gina and the rest of the team with their clinical insights and expertise that helped us get the right contributing factors and the right solutions for those problems. I played a small part in helping to organize those thoughts a little bit.
Yeah.
Well, and we've heard so many positive comments already from everyone about just the power of team. And certainly, Eric, your role as trusted guide for this group has been instrumental. So now, Chris, we're going to jump back over to you. Talk about successes, wins. What worked?
Oh, so many things. But one of our biggest wins was the way our team our team building was so strong. It helped us to build the trusting relationships with one another. That really helped to create an environment where the team members felt comfortable speaking up and sharing those ideas. Like Gina had mentioned, no idea is a bad idea. That really helped. That was probably the biggest contributing factor to the success of this team. It helped to build psychological safety. We had mutual respect through that. And we brought a sense of fun into the work. I mean, CAUTI prevention is not fun in general, but I think we did the best that we could to make it fun. We met frequently. I think that really helped too, is we didn't let too much time in between meetings go before we had our next meeting. It really helped spark the conversations and keep people accountable for what they were asked to do and their takeaways. Recognition was another win for us. We really recognized each other's work and really celebrated the small wins, no matter how small they were. We did that publicly. We didn't do it privately in an email to each other, but we called each other out in the meetings with the work that they did. We also found ways to make the work enjoyable. We brought some fun and creative ideas. Gina's very creative. I am not. That's Gina. And she initiated the first inaugural annual Halloween break room decorating contest, and the champions on the team really took that and ran with it. And that's still going on today. So I feel like, we've had lots of wins.
You mentioned so many good tidbits there. I wonder, for our listeners and for me, I mean, one of the things you mentioned was the importance of checking in frequently enough, not letting too much time go. How do you gauge that? I mean, it sounds like you hit around the right formula for this particular task. What's your thoughts on how frequently should an improvement team meet?
We were very fortunate in the sense that we were given a very short timeline that we had to make improvements. So we determined every week to be our meeting cadence. And we eventually transitioned to in-person, even though we all had to mask and go through all the things coming into campus, but also gave members the opportunity to join online. But having that face-to-face, well, with the mask on, opportunity to interact with each other really helped with that team building as well. But I think that initially the weekly really kept things going, and eventually it went to monthly, and then depending on our tiered escalation, depending on our CAUTI rate, we would meet more frequently. But I think really to get things going and to keep it moving along and not draw a quality improvement project out too long, I think the weekly to begin is a good amount of time.
And you just mentioned another thing that I'd love to hear your thoughts on this. I think everywhere, at least in the United States, if not globally, is struggling with virtual only versus hybrid versus in person. And it sounds like really in the midst of a certain amount of controversial times to meet together, you made a decision to meet together in a more physical way. What did you find was better about building teamwork, in that way versus virtual only? I'm just kind of curious what your thoughts were.
The individuals that attended the in-person part of the meeting and didn't join virtually really had more engagement and felt more comfortable speaking up, actually. They were present. They weren't multitasking. We all know sometimes when we join virtual meetings, we're also doing something else. So their individual attention was more evident on the in-person side of it.
Thanks. Well, Gina, your team had a lot of successes. Maybe as the infection prevention specialist, you can tell us what were some of the kind of concrete gains that happened as a result of your team's work. What would you say were some milestone improvements?
Well, I think that one of the best things that we did was form CAUTI champions, engaging the frontline nurses, because the information that they would bring to us was really what was happening out on the units. And so if we had real life information coming to us, then we had, that pathway of information where we could identify the gaps and look for solutions. So I think that having the champions that be engaged was really important. And they also helped us determine like how often do we need to meet. And the champions met every month regardless throughout the entire time. Although some of them didn't meet with us weekly in the beginning, there was a champion meeting every month for many years where we would plan all of our activities, our prevention activities. So I think that probably the greatest thing that we did was engaging the champions on each unit, and they volunteered. It's a volunteer activity. And so those champions were passionate about CAUTI prevention. And so they would find opportunities on their own units and look for opportunities and then share that with the other champions. Like, hey, I noticed this on our unit. This is what I'm doing to help. And they would share ideas and become inspired during the monthly meeting. So there was a lot of value to information sharing between the
That
champions.
local engagement. You know, I'm sure our listeners are wondering, and I know I am, did our CAUTI rates improve?
Yes, they did. Eric,
Yeah.
does Eric have the information pulled up? They
No
sure
sharing,
did.
no visual sharing, Eric, but did they improve?
They have improved immensely. Yeah, we saw something like a 50% decrease in our CAUTI rates down to levels that we had not seen before. And compared to like hospitals, we're well below the thresholds that were expected of us from like US News or World Report or CMS. So yeah, from a measurable standpoint, we succeeded greatly. And I would say from a non-measurable standpoint, we also improved greatly.
Yeah, that's incredible work. So Eric, let's just stay with you now. Tell us, what do you have now? What's current state?
All right. So the current state of the project, it's really a reflection of what quality improvement in healthcare looks like. It's continuous. The work we started back in 2020, it was very successful, and it showed that our approach worked. Since then, we have experienced a lot of change, just like everyone else. Things including staff turnover, new technology implementations, documentation demand changes, and other competing priorities that have affected how consistently some of those practices are carried out. But I think what's really encouraging is that the foundation we built is still there. That architecture for collaboration, it's in place today. We have a strong culture where people feel comfortable to speak up, identify problems, and work together to improve care. The passion and commitment from nursing, infection prevention, providers, quality, and leadership, those all remain really strong. So right now, we're taking what we've learned from that original project and we're adapting it to today's environment. We're not starting from scratch, but we're building on a proven approach and refining it to fit our current workflows. That's really the nature of continuous improvement, right? Learning, adjusting, and continuing to move forward in pursuit of better outcomes.
Well, that's fantastic. So an amazing amount of work and wonderful results. So I'm wondering, Bridget, a lot of other organizations might be wanting to start something like this. What would you say to another organization that says, gee, we'd like to pursue CAUTI prevention, but they want to do it in a way that builds teams that can be translational, like Eric just shared? What would you say to them? How do they do this?
I'd have to say that one of the main reasons why we were so successful was because we didn't have all the answers. And I think if you go into that together, knowing a problem but not knowing all the answers, is that we trusted one another and we listened to one another, and everyone had a voice, as previously said. So we stayed focused on our shared purpose. We kept our patients safe, even though circumstances were unlike we've ever experienced. That we all agreed that despite the challenge of the patients deserve safe care, regardless of their circumstances. So as long as you have that as a group or as a mission statement for your team, an unforeseen challenge may come up, but that doesn't change. Change means you have a commitment still to your patients. So when people feel supported, they're always willing to speak up, share ideas, solve problems together. And that's what creates lasting change and lasting collaborative teamwork. So this wasn't mostly about the award we received, but celebrating it together for us and for our patients and for the outcomes. And this is how meaningful improvement happens.
Yeah, wow. Well, we've learned a lot from you all today, and I just want to take a moment to say thank you, really, for your willingness to share your enthusiasm and your passion and your learnings with us and with our listeners. But also, thank you on behalf of our patients and our staff for the work that you've done at Mayo Clinic in Arizona. It's very exciting. I know as one of the leaders in quality, I get to listen in on the weekly leadership meetings, and just seeing the progress that you all have made and how things have come along has really been astounding. So thank you so much for this. Any parting remarks that you all have for our listeners?
If you have one more tidbit to share, please do.
Yeah, I just wanted to further emphasize what Bridget was saying. Like, we didn't have any egos on the team. And, sometimes in healthcare, when you step into a project, there's that fear that you don't know it all, or that if you're wrong on something, that there could be, like, if you do the wrong thing, that there could be consequences. Or you could get in trouble, or, just by doing the wrong thing or making the wrong decision, because we were making decisions for patient care. And so there weren't any egos, and it was great because we weren't looking at things as a people problem. We were looking at all the decisions and the things that we were making. We're looking at things as a process problem. So anytime that anything went wrong, because there were some things that we did that didn't work out.
Mm-hmm.
And some moves that we made that, well, okay, well, we tried that, but it didn't work. And there was never any, oh, well, we shouldn't have done that, or whose idea was that, or, there was none of that kind of stuff. It was like, well, we tried that and it didn't work. Okay, well, where do we go from here? Let's just toss that aside and, we'll look to do something else. So it was okay to try something and not have it work.
Wow.
And sometimes I think in healthcare, it doesn't always feel like it's safe to make a mistake or to do something that doesn't work. And on this team, it was fine too.
Well, that's great. Well, we do have to come to a close today, but it's been really great sharing this discussion with you. As we heard today, reducing CAUTIs is really not the work of one person or one policy or one intervention or just following a rule book. It really took the team in this case, and I think in most cases, to see the problem clearly, to listen to each other with a lot of curiosity and willingness to try things, try new things, but all the while keeping patient and staff safety in mind, and really pursuing that shared goal in an organized and disciplined fashion with the help of someone like Eric here. Really learn from your barriers. The CAUTI Prevention Work Group here, I think, really reminds us that quality improvement is technical, but it's also very human. It's a very human endeavor. It's not just about knowledge, it's about working together. Some details appropriately stay within the team and local work. But I think the broader lessons that we might have learned at today's broadcast should really be shared. So here's the challenge, I think, for each of our listeners. Look at one quality problem in your own setting and ask not only, gee, what needs to change, but also what team needs to form, strengthen, or reconnect so that the change can begin and the change can last? How can you be a change agent? You've heard some great thoughts during this broadcast. Excellence in healthcare is not achieved in isolation. It's created by people who choose to work together with that kind of clarity, humility, and purpose. So we've come to the end of our podcast. We're glad that you could join us. We hope that the information is insightful, valuable, and inspiring. Again, Mayo Clinic's Key into Quality podcast aims to highlight practical first steps in addressing important quality challenges in your organization. Our goal is to improve quality for patients and for the populations that we all serve. If you enjoyed this podcast, we'd be grateful if you left us a review on Apple Podcasts, a rating on Spotify, or feedback wherever it is that you listen. You can also follow us on your favorite podcast platform. Let others in your organization know about the podcast so that information can be shared. Until next time, goodbye.